Bismillahirrahmanirrahim. Assalamu alaikum everyone. We are in the middle of discussing non-communicable diseases, and in the previous sessions we have discussed these non-communicable diseases in a general way, their epidemiology and the preventive strategies, as well as the risk factors that are common to these groups of diseases. And we have also talked about hypertension, which is a very important non-communicable disease and a precursor to many complications and many other non-communicable diseases. So we discussed about hypertension in our last session in detail. Today we are going to discuss about another one of the non-communicable diseases, which is stroke, and it is one of the complications of hypertension as well. So let's start with stroke. Stroke, which is also known as apoplexy, it is an acute, severe manifestation of cerebrovascular incident. It causes both physical and mental disability, and it may be defined as rapidly developed clinical signs of focal disturbances of cerebral function that last more than 24 hours or lead to death, with no apparent cause other than vascular origin. The 24-hour threshold in the definition is important because it helps excluding the transient ischemic attacks, or TIAs, which you must have heard about. These TIAs are last less than 24 hours by definition, and if such incidents last more than 24 hours, or they lead to death, uh, that may be within 24 hours their death, then they are called strokes. Also excluded are patients with stroke symptoms that are caused by subdural hemorrhage, or tumors, or poisoning, or trauma. We know that trauma and tumors pressing on some um, parts of the brain can cause symptoms which are similar to or same as stroke, but those are not called stroke. Stroke only involves the rapidly developed clinical signs of focal disturbances of cerebral function. So we have defined stroke as a cerebrovascular incident that results in a cerebral deficit, and this disturbance of cerebral function can be due to three possible morphological abnormalities. Those three abnormalities are either stenosis, which we know is the narrowing of the vessels. It can be occlusion of a vessel that supplies the brain or cerebrum, or it can be due to rupture of one of the vessels. So it can be due to these three basic morphological abnormalities that can lead to development of cerebral function disturbances or deficit, or in other words, stroke. This dysfunction of brain or neurological deficit may result or may manifest as various neurological signs and symptoms, and that are proportional to the extent of the manifestations of these signs and symptoms are proportional to the extent uh, to which the occlusion or stenosis or a rupture has occurred, and the site of the area which is involved. And these signs and symptoms can include coma, hemiplegia, paraplegia, monoplegia, multiple paralysis, speech disturbances, nerve paralysis, as well as sensory impairment. These can occur in combination, or these can occur individually. Of all these signs and symptoms, the hemiplegia is the most encountered neurological disorder in case of strokes, and in 90% of the patients, the manifestation of stroke occurs as hemiplegia. So far we have established that a stroke can be due to occlusion or stenosis or a rupture of some vessel that supplies the blood to a cerebrum uh, or other parts of the brain. It can be thus divided into two major subtypes: the ischemic stroke and the hemorrhagic stroke. Ischemic stroke is more common compared to hemorrhagic stroke, and this ischemic stroke can further be divided into three subcategories. This is more related to pathology, but you must know it in community medicine as well. Ischemic stroke can be due to lacunar infarct or carotid circulation obstruction or vertebrobasilar artery obstruction. The hemorrhagic stroke can be spontaneous intracerebral hemorrhage, or it can be subarachnoid hemorrhage, or it can be intracranial aneurysm, or it can be AV malformations. Remember that subdural hemorrhages are not included in the etiology of strokes. So these are two major varieties of stroke, or the two syndromes that manifest due to these conditions vary according to the etiology. It can be ischemic or it can be hemorrhagic. So next we shall look at the epidemiology of stroke, or the problem statement uh, that 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 will show us the burden of the disease. We have already discussed in our earlier lectures that NCDs, they are responsible for a large number of deaths as well as disabilities in whole of the world, in developed as well as developing countries. And in fact, in developing countries, the morbidity and mortality due to non-communicable diseases is rather disproportionate. Stroke is no different. It makes an important contribution to morbidity and mortality and disability in developed as well as developing countries. The difference lies in the two regions uh, about the average age at which stroke occurs. In developed countries, the age is higher. The average age at which the stroke occurs is higher, is around 73 years of age. In developing or underdeveloped countries, this average age is lower. Also, the probability of a first stroke or first transient ischemic attack is around 1.6 per 1000 and 0.42 per 1000 respectively in developed and developing countries. So uh, you can guess from this that the probability of a first stroke or first EIA is a bit higher in developed countries. In less developed regions, the average age of stroke is less due to different population age structure. We have more number of younger people in our population, as you have studied in demography. So the incidence of stroke among younger population is higher in developing countries. This is all due to different population age structure. The stroke patients are at highest risk of death in the first weeks after the event, and between 20 to 50% they die within first month, depending on type, severity, age, comorbidity, and effectiveness of treatment of complications. So early on, after the stroke has occurred, the probability of dying is more, and it is dependent upon the type of stroke, whether it was ischemic or in fact hemorrhagic. How severe was it? How severe was the blockage in the vessel, or how severe was the hemorrhage? That will affect the outcome. Also, the age. Older the age, the probability of dying within the first month increases. Then, if there are comorbidities present, if the person is diabetic and has other diseases as well, and then goes on to have stroke, the probability of dying within the first month increases. And of course, the effectiveness of treatment of complications, and the availability of treatment, availability of health services also have an effect on mortality. The people who survive, they are left with mild or moderate or severe disability, or they may have no disability. This also again depends upon many factors. Considerable spontaneous recovery is seen in up to 6 months, uh, but patients with history of stroke are at high risk of a subsequent event of around 10% in the first year and 5% the year thereafter. So once the person has had a stroke, the chances of having a second stroke, they are higher compared to the persons who have never had a stroke. One interesting bit of information is that the mortality from stroke has been on the decline in many countries for the past several years. This decline, in fact, has occurred before modern treatment methods became available. The treatment methods that we see today that are offered to stroke patients, before even they were available, the mortality due to stroke was on the decline. This decline in the mortality can be associated or attributed to some social and economic changes. As the economic transition occurs, the uh, the ability or the access to healthcare facilities also improves, and the level of social change is also associated with declining mortality. That, for example, if there is higher levels of literacy or higher levels of awareness, the people will seek proper medical care for their ailments and not go to quacks or hakims, etc. So that can result in lower mortality. So, what are the risk factors, the environmental or external risk factors that are responsible for stroke? These are also modifiable risk factors. The most important, the single most important risk factor for stroke is hypertension. And this is the main risk factor for thrombosis as well as cerebral hemorrhage. So, uncontrolled hypertension is the most significant and the biggest risk factor for stroke. And hence, you can conclude that the risk factors that are responsible for hypertension, which we have discussed in the previous session, they are also responsible indirectly for a stroke. Then there are some other factors apart from hypertension that can result in increased incidence or increased chances of stroke. And these may be cardiac abnormalities, for example, left ventricular hypertrophy. This can result in an increased risk of stroke. Cardiac dilatation can result in an increased risk for stroke. Diabetes is another risk factor, elevated blood lipids, obesity, smoking, glucose intolerance, blood clotting, viscosity, oral contraceptives. Uh, these are all the factors that are responsible independently of hypertension for development of stroke. You can see that you will see that these risk factors that we have talked about, they are also common to many other non-communicable diseases. For example, ischemic heart disease or hypertension. But the risk factors for stroke, even though they are similar, their relative importance differs. For example, diabetes may be much more relative, or diabetes may be much more important for ischemic heart disease as a risk factor. It may not be that important for stroke, but it is still there. It is a risk factor. So risk factors, although similar, their relative importance differs for different non-communicable diseases. So we did talk about transient ischemic attacks in the definition of strokes, and we said that strokes are those which last longer than 24 hours. and if such an event which results in neurological deficit results less than 24 hours, then it is labeled as transient ischemic attack. These are episodes of focal, reversible neurological deficit of sudden onset and of less than 24 hours duration. So, if a deficit has occurred, a neurological deficit, which was reversible, importantly, and it only lasted 24 hours, less than 24 hours, then it will be labeled as transient ischemic attack. Now, why are these important? Why are they discussed here? Because one, they show a tendency to recur. Once a transient ischemic attack has occurred, there is chance, or there are great chances that it will happen again. They will recur, and they are also warning signs of stroke. After TIA, the chances of stroke they increase manifold. So once a person has had a TIA, there are chances that he or she may go on to have an episode of stroke as well. These TIAs are due to microemboli in the vessels. So we talked about the risk factors, the environmental or external risk factors that are responsible for, or that are uh, part of the causative chain of strokes, and we talked about hypertension in that being the most important and the major risk factor for stroke, and some of the other environmental factors. Then again, there are some host factors that are responsible for stroke, and these host factors are non-modifiable. First of all, the age. A stroke, although can occur at any age, but usually the incidence rate increases with increasing age. And globally, about 47% of all stroke deaths occur in persons over 70 years. Strokes that occur below the age of 40 years are usually due to a younger population and shorter life expectancy, as we have discussed earlier. In developing countries, in our part of the world, in Pakistan as well, we have the major chunk of our population is young. The younger lot has a bigger proportion in our population. So the incidence automatically of stroke is higher in below 40 age group in our part of the world. Sex is also a host factor. The incidence rates of strokes are higher in males than females, and this is true for all ages. And then personal history is also relevant. Three-fourths of all stroke patients had some associated disease, um, diabetes or some other cardiovascular disease. So if a comorbidity is there, the chances of stroke they increase. So these are some of the host factors, non-modifiable, of course, but that are a part of the multifactorial causation that results uh, in development of stroke. Finally, we will talk about the prevention strategies that can be adapted for prevention of stroke. So in primary prevention, we know that hypertension is the single most important risk factor for development of stroke. So all the preventive strategies that can be applied to control of hypertension are true here as well. They are relevant here as well. The priority should be to control arterial hypertension. If you can control hypertension, that will result in control or prevention of a stroke as well. Then the transient ischemic attacks are one of the earliest manifestations of stroke. If you can detect TIAs early, and then you can focus on the person promptly and treat him or her for prevention of the stroke. So important is to be able to identify or detect the episodes of TIAs when they occur. Then all the risk factors that are associated with hypertension and other non-communicable diseases are also relevant here. So control of diabetes, elimination of smoking, and management of and prevention of other risk factors, obesity and lifestyle, the fat intake, etc. They are also relevant in the primary prevention of strokes. Then there is the secondary prevention. That is, once the stroke has had occurred, the secondary prevention will focus on limiting the complications. It involves the availability of facilities for the long-term follow-up of the patients, and it also involves the education and training of health personnel and of public, so that secondary prevention can be made possible. So these are the preventive measures that can be undertaken for prevention of a stroke. Thank you very much. In the next session, we will focus on ischemic heart disease as well as another disease, another non-communicable disease, which is rheumatic heart disease. So till then, goodbye and thank you and have a nice day.